Hello, my name is Meg Huang, and I'm the Executive Director at the Center for Connected Health Policy. And today I'll be talking about recent telehealth policy changes in COVID-19. Few disclaimers to start with today. Any information that I provide today should only be considered for informational purposes. It is not legal advice. If you are looking for a legal opinion, I suggest you seek legal counsel. And if I happen to mention any company or show any type of equipment, please know that neither I nor CCHP have any type of financial relationship or arrangement with such a company. Center for Connected Health Policy was established in 2009. We're a program underneath the Public Health Institute. We became the federally designated National Telehealth Policy Research Center in 2012, and we've been working in that capacity ever since. We also do a variety of other projects with various partners. One of the things that we do at CCHP is that we do a 50-state report on telehealth policies for all the state laws, Medicaid policies, and regulations related to telehealth, as well as tracking federal policy as well. We are also the administrator for the National Consortium of Telehealth Resource Centers, and we convene a group in California known as the California Telehealth Policy Coalition. The National Consortium of Telehealth Resource Centers are 14 telehealth resource centers who are all federally funded to provide technical assistance on telehealth. CCHP acts as the National Policy Resource Center. There's also another national center that works on technology, and then 12 regional resource centers that cover specific states. I like to call them a one-stop shop for your telehealth questions, so please definitely reach out to your appropriate telehealth resource center. But if you get one of us, I also like to say you get all 14 of us helping you too. I mentioned earlier that we do a 50-state report. We also put that information on our website. It is publicly accessible. That is a snapshot of our website. It's an interactive map. So if you are interested in a particular state, you just click on it and the information will come up. Currently, the information on our website as of March 31st, 2020, the information on our website is good through October 2019. We are in the midst of our spring update, and we hope to have that up in a couple of weeks. So today I just wanted to talk about some of the telehealth policy changes that have occurred both on the federal and state level in regards to telehealth and COVID-19. So today, as of March 30th, 2020, and please note the date because policy is moving really quickly. It is changing very rapidly. So the information I'm providing you today is just good up through today of March 31st, 2020. So geographical limitations. Before COVID-19, when you were talking about telehealth and reimbursement in the Medicare programs, you had limitations on how you can utilize telehealth, where it could be provided and who could receive the services, and what services they could receive. One of the limitations was where was the patient located when the telehealth interaction took place. And in law, it said it needed to be in a rural area or non-metropolitan statistical area, and the patient needed to be in basically a healthcare type of facility. So these two restrictions on where the patient was located were waived by recent changes with the bills that have passed through Congress and was signed by the president. So the geographical limitation was waived as well as the site location. So it means basically the telehealth interaction could take place anywhere for a Medicare enrollee, and they would be able to get reimbursed the provider based on the location. Providers. Now, before COVID-19, there was also a very limited list of providers who can provide services via telehealth and get reimbursed by Medicare. Doctors, midwives, psychiatrists, dietitians. It was a very short list. Missing from there were some of the allied health professionals, such as PTs and OTs, but also missing were federally qualified health centers and rural health centers. A recent congressional bill, HR 748, did add FQHCs and RHCs to be eligible distance site providers. Now, that's a recently passed bill, so we are still waiting from CMS guidance on how exactly that's going to work in Medicare, but know that the law was passed that in this emergency situation, an FQHC and RHC can act as a distance site provider providing telehealth services and get reimbursed by Medicare. But the more finer details, we're still waiting for CMS to tell us exactly how that's going to work. Modality. So again, pre-COVID-19, live video was essentially the only modality that you can use to provide telehealth in Medicare, unless you were in Hawaii or Alaska, and then you're allowed to use store and forward. Right now, there was a little bit of change between the two bills. So two bills have passed in Congress, HR 6074, that's the first one, and then HR 748, which is the more recent one. What happened in 6074 was it had put language in there regarding the ability to use smartphones, but it had to have an audiovisual component. HR 748, the more recent bill, removed that language. So what that eventually does is that it opens up then it doesn't open up, but it refers back to what was an existing law pre-COVID-19 of what the type of technology you can use to provide services via telehealth. So in law, it refers to it as telecommunication systems, and it doesn't define what exactly that means. However, if you go into federal regulations, it does say it needs to be audio and visual, so live video essentially. But that's in federal regulations, that's not in federal law. So that does mean that CMS has a bit of flexibility in how they define telecommunication systems. So theoretically, they could say an audio-only telephone could be a way in which you can provide services, and that could be another way in which to expand the available services, especially for those who may not have access to the technology. There are also a grouping of other types of services that are not called telehealth or regarded as telehealth by CMS that do allow the use of phone, and I'll talk about those a little bit later, so that's also another option. Services. So one of the big changes that came down literally last night on March 30th, and this is being recorded on March 31st, CMS did expand the list of services that were eligible to be provided by telehealth. I've given just a really short example here of some of the things that they included. We are providing links to access the actual guidance that CMS put out, but such things as ED visits that are level 1 through 5, and also initial hospital care, hospital discharge codes as well. So also keep in mind, they do go by, when they say that we're reimbursing for services, they do go by specific codes. So make sure the service that you're trying to provide fits into the definition of those codes. Facility fee. So again, right now for facility fee, who gets that? It's really what is an existing law. So you go back to the pre-COVID-19 existing law and what it says there. In HR 6074, it said to utilize telehealth to provide service under a waiver, I need a prior existing relationship. That was language put in the first bill, 6074. It was taken out by HR 748. So right now, they're saying that you can use telehealth in Medicare to provide services to both new and established patients. Do I have to pay co-pays and out-of-pockets? Do they still apply? So the Office of the Inspector General has said, we're going to give flexibility to providers to reduce or waive those fees. Now, a lot of people have asked questions about HIPAA and what does it mean in that they're waiving HIPAA requirements. What it essentially means is the Office of Civil Rights, who basically finds and enforces HIPAA for the feds, is saying that we're going to use discretion and waive penalties for HIPAA. So they're relaxing things a little bit. But keep in mind, that is only one area of personal health, protected health information you may need to consider. You still need to consider what the states might be asking as well. And some states are relaxing some of these protections and others are not. So while OCR is saying we're not going to penalize you, that doesn't mean the states may not take action. Licensure, also another area where people were confused because it was announced a few weeks ago, say the feds are relaxing the licensure laws. And what does that mean? Because actually licensure is underneath the states to control, not the feds. So what it meant on the federal level is that under Medicare, there are certain requirements that say that you need to be licensed in the state where the patient is located. So Medicare is saying that it will relax some of those regulations, and as long as the provider meets certain requirements, such as they are licensed in the state that they're practicing in, that they are not prohibited from providing services in the state that they're trying to provide services to. If they meet some of these qualifications, they're able to provide services without getting a license in that patient's state. Other things that have been changed as well. So these are kind of more specific pinpointed policies that have been kind of a hurdle to telehealth, but they've been relaxing them. So for dialysis patients, when you have patients who are getting home dialysis, in the first 3 months when they first start that, each month they have to have an in-person visit for those first 3 months. And then for the following consecutive months, they would have to have an in-person visit every 3 months. They're saying you can do that via telehealth. You don't have to do that in person. Hospice. So during this period, the secretary is allowed to say that there's this requirement that the hospice physician and nurse to determine continued eligibility for hospice care. They needed to have like a face-to-face encounter, again, saying that you can use telehealth. It doesn't have to be in person. Another interesting, just quirky type of policy that's been kind of an issue pre-COVID-19 that telehealth providers were brought up is like when a provider is providing their services from the home, they have to put their home address as like where they were when they were providing the services via telehealth. And the problem with that is that that information is publicly accessible. So you had a lot of providers very hesitant about that. CMS is saying that you don't need to do that. You can just put down your currently enrolled facility location. So that is another relief, I think, for providers who do provide services via telehealth. And then there was another thing about requirement that physicians and non-physician practitioners to perform in visits in nursing hospitals. They're saying that if it's appropriate to do so, you can do that via telehealth. So again, relaxing some of these more specific type of policies that are out there. So a couple other things to be aware of, some of those additional codes that they have added, all included nursing facility codes. There were a set of codes where they said that they are audio only. So this is sort of one of those areas where they're saying you can use phone to provide these services. And it's those specific codes that have listed there. There are also frequency limits and when you can do visits in like certain situations. So for example, for a skilled nursing facility, you can only use telehealth like once every 30 days. Subsequent inpatient visit, it was limited to once every 3 days, and then critical care consult, it was limited to once a day. Those are waived. So those limitations do not apply anymore during this emergency situation. They're waiving those limitations. There are also questions about, hey, if I like reduce my fees or I'm trying to do a telehealth program, don't I run into, Stark law issues? And they are providing some relaxation of the Stark laws to make sure that providers who are trying to use telehealth don't hit up against these types of barriers as well or concerns. And in supervision, they did change some of the supervision, allowing them to use telehealth. So you can check the documentation. The links that I have on the bottom there, like link to all various resources or various sources of this information. So you can look at them in greater detail and see what's available. Other changes. So this was done underneath HR 748, again, the most recent bill that was passed and signed into law. There were some changes in Veterans Affairs regarding telehealth. So they would agree to enter into short-term agreement basically to expand broadband services to vets so they can access mental health. And also waiving, again, some of those like requirements that you sometimes run into a program where it says, oh, you need to do this in person, or you need to get some type of written consent, like allowing that to be done over telehealth or do a verbal consent over phone or something. And then also ensuring that the secretary ensures that the telehealth capabilities are available to case managers to use when dealing with vets. Other federal telehealth policy impacts. So when you are prescribing a controlled substance, what controls is actually federal law. The telehealth section was placed into federal law under something called the Ryan-Haight Act. So you sometimes hear the shorthand of, the Telemedicine Ryan-Haight Act section. So underneath that, there are about 7 exceptions where you can use telehealth to prescribe without first having examined the patient in person. And they're very narrow, something like, the patient is in a DEA registered facility when the telehealth interaction takes place. But one of those exceptions is that when there's been declared a public health emergency, and that kicks in like one of the exceptions, which says that you can use telehealth to prescribe, but you have to essentially meet these 3 bullet points, which is it's for a legitimate purpose, you're using live video, and you're following all other federal and state laws as well. And that's the link for the DEA guidance on that. Now, we get a lot of questions on what can FQHCs and RHCs do, and I did mention earlier that HR 748 allowed FQHCs and RHCs to be a distance site provider underneath Medicare to provide telehealth services. Again, nothing as of this time, March 31st, 2020, around 3 p.m. Pacific, nothing has dropped from CMS saying exactly how that would work. It's just in statute at this point, so we're still waiting to see what the exact protocols and details are from CMS on how that's going to work. But it did say in the bill they can act as a distance site provider. What it also said, though, is that they're not going to get their PPS or error rates. They're going to like base the calculation essentially on fee for service. So that's the special reimbursement methodology. So what that eventually is going to look like and how much they're going to get paid for delivering the service, not quite sure yet. One of the things that CMS is still working on. So there are other services that FQHCs and RHCs can provide underneath Medicare that aren't considered telehealth. They use telehealth technology. I mentioned that briefly earlier. I'll go into that in a second. Also be aware for FQHCs and RHCs, state Medicaid and health plan policies vary. So you're going to have to check what state that you're operating in to see what their telehealth policies are for Medicaid, and health plans, what they want to do in regards to you with telehealth. So these are the other types of non-telehealth services, but they use telehealth technologies that are available underneath Medicare and that you can get reimbursed for. Virtual check-in codes. It is exactly what it sounds like, quick check-in, and you can do it virtually, either a live video, store and forward, or over the phone. FQHCs and RHCs have their own codes, G0071. Everybody else use the other G codes. And then there are other types of services that are available too. Interprofessional telephone codes, e-consult, that's a provider-to-provider consultation. That is not available to FQHCs and RHCs. And then a series of remote patient monitoring codes. Keep in mind, each of these codes have their own type of requirements and definitions that you need to meet. Like for example, the virtual check-in code, in order to use that, your check-in must not have been 7 days. There couldn't have been like a visit with the provider 7 days before, and it doesn't result in a visit like 24 hours or as soon as the available visit afterwards. Basically, it's a quick check-in. They went it to triage. It's just to make sure it's not like that you needed a more complex visit. So they have their own different requirements. Some of like the remote patient monitoring services, again, they have certain requirements to meet in order to use the code. Chronic care management, for example, the patient needs to have 2 chronic conditions or be at risk of hospitalization or death within the next year or something like that. Like very specific types of limitations and requirements that you need to meet in order to like utilize that code. I do want to touch a bit on online digital evaluation and online medical evaluation. It's an online portal, and it was not available to FQHCs and RHCs, but what was also issued was an interim final rule that would say that FQHCs and RHCs, you can use some of these codes. It's not finalized yet. That's why I've got a little question mark there for today. Again, March 31st, 2020. And I hate to keep repeating the date, but I just want to make sure when people are watching this, they realize when this was recorded. So that is something, again, that we may have to wait for like clearer guidance from CMS once they've gone through this process of like, introducing interim rules. What's going on the states? So pre-COVID-19 Medicaid reimbursement, everybody was reimbursing for some live video in their Medicaid program. And it varied from being very narrow to just like a couple of services such as mental and behavioral health to like more widespread services like practically everything. Store and forward remote patient monitoring, not as popular. Most states had some type of private payer law on the books. And again, it ranged from, a state that said health plans, you can cover telehealth if you want, all the way to health plans, you shall cover telehealth. And by the way, you shall pay the same amount and it should be treated as basically the same as you would in person. And everybody else kind of falls in between there. What does that look like in the COVID-19 world? Well, all the states have different policies and different ways of how they address telehealth, both on the private payer side and also in Medicaid side. And a lot of them are running into issues of like, we're not allowing it to be used to its fullest capacity. So they've issued emergency regulations, or they've done guidances with their Medicaid programs on what they're going to do. So some of the common changes that we're seeing on the state level is the big ones, allowing home to be an eligible originating site. Pre-COVID-19, actually not a lot of Medicaid programs were allowing that. So you're seeing a lot of states say, absolutely allow the home to be originating site. They're also allowing telephone to be used to provide services. So actually pre-COVID-19, most states either had a definition in policy or in statute or regulation that said what telehealth or telemedicine, depending on their term was, that they're using, what it meant, and most of them explicitly excluded phone. So when you see some of these emergency issuances and guidances, you'll see them saying something like oh, we're expanding telehealth and phone. And that's why, because it wasn't in the definition to begin with. So a lot of states are also allowing telephone to be used. And also, a lot of states are issuing some kind of guidances on health plans and how they are supposed to treat telehealth. Some of them are being very prescriptive and saying, you shall cover these telehealth services and you will pay the same amount and you will let network providers do it. And others are a little bit, more gentle, or is the word, or a little bit looser with like, what they're saying, like you should do this health plans. So depending on the state, it could be, it could vary widely. And some health plans are just voluntarily doing it. I just saw recently, like Montana, where the health plans there just agreed, saying we're just going to cover telehealth, and that could be happening too in your state. Less common policy changes. So these are things we're seeing, but not as frequently as the other ones that I just covered. So expanding to other modalities besides phone, allowing like store and forward version to be used, or remote patient monitoring, not really as common. Phone is like big one that we've been seeing. Expanding the list of eligible providers to include others such as allied health professionals. Again, not a lot of expansion on who the eligible providers are. We are seeing that in some states, but that's been kind of like not as popular as some of the other changes we're seeing. And then waiving consent requirements. So actually quite a few states have either, again, on their books or in their policies, some sort of consent requirement when they're using telehealth that you need to get. And we're seeing like some of them either not necessarily waiving, but relaxing them and saying like getting a verbal consent is fine too, just make sure you record it in the health record. So one thing that I want to touch very briefly on, there's 1135 waivers. I have not had a chance to go through all of the 1135 waivers, but some of the things I did see was something like Florida and Arizona had, and that was regarding being able to pay for providers who are not enrolled with their Medicaid program. So again, one of those rules that may like inhibit the use of telehealth in this emergency situation, they're saying like, yes, you can go ahead and pay that if they're not like regularly enrolled in your Medicaid program and they did provide services to Medicaid patient. The image to the right, it is something that we have put together. It is sort of a overview of some of the telehealth policies, emergency policies that have gone on in the states based upon kind of their subject matters. This is not very detailed. It does not include the 1135 waivers. It's like kind of a quick hit. Do they do telephone? To say something about telephone, there's a column there and there's like just a yes. All the items are hyperlinked to the official source, so you can go and check that, but that is something that we are making available to everybody, and we will update that regularly as new things come in. And these are just a couple links to resources that we have on our website. Again, I suggest that you check our website frequently because policy is moving very quickly. So we are almost doing daily updates with new information that comes in. And hopefully, people will find all this useful and valuable to them. Thank you very much. I hope this has been helpful for you. We will be doing future videos. Again, definitely if some of these policies change, we will record a new video. We'll also be looking at doing a more state-specific video as well. So thank you very much for joining us, and definitely let us know if this has been helpful to you. Bye-bye.